We'll move on to the next topic of the day, which is interpretation of CT scan of the temporal bone. I had a few slides on the initial physics and all those things, but we'll skip these because I saw that most of this has been covered by Amitabh sir. So we'll just go on. As you know, what we are trying to find is the clinical correlate, the radiological correlate of what we are seeing here. So a small attic perforation can have a wide spread, and the CT scan is the only thing which is going to provide us an idea, the ideal roadmap of the surgery and the extent of the disease, right? So this is the first CT scanner rather at the Atkinson Morley Hospital in London, and this person is, any idea who this is? Hounsfield. So Sir Godfrey Hounsfield and Alan McCormack, who have received the Nobel Prize for their work on CT scans. We'll just run through this. I don't think we need all this for this. So as we know, the temporal bone is a complex bone made up of 4 parts, isn't it? The kiki, squamous, tympanic, petrous, and styloid. Mastoid part is derived from the tympanic part and the petrous part. It is not a embryologically distinct part as such. Okay? And housed within this, there are numerous minute structures which help us to hear and to maintain our balance. So we will chart this C. Let us see. I'll just skip all these things about Hounsfield units and all those things, and we'll just move on to reiterate the soft tissue and the bone window. For this, we have to know 2 things. One is the window width and one is the window level. If we take, just to make things simple, if we have a high window level and a large window width, then we have a bone window, which will help us in seeing the bony structures, while a lower window level and a shorter window width will help give us soft tissue windows, right? So what difference it can make? It can make a lot of difference. So you can see we are simply skipping this lesion. These are the same axial cuts on bone and soft tissue windows. We are simply missing the lesion if we have a bone window with us. But for all practical purposes, for chronic otitis media, which is uncomplicated, we will need to know about the bone windows. You know about the planes, I will not go into this. Right, we will start with axial scans. We will just run through the normal anatomy that can be seen and what you expect to see on which cut, okay? Because otherwise you won't be able to see the pathology. During axial scans, many prefer to go from below upwards, but I prefer going from above downwards because there are less number of structures, so it makes the CT cut less complicated. So we will start high above, and then we see that we have to realize that if we have to understand CT scan of the temporal bone, it has to be all in relation to the course of the facial nerve. You have to follow the facial nerve accurately as it is coming from the pontomedullary junction. You cannot see it on CT scan obviously. From the cisternal segment to the canalicular segment, labyrinthine, tympanic, and back again, and this is in relation to the vestibule. The evaluation of the facial nerve and the vestibule are 2 things which you have to understand. The semicircular canals, when you are growing from above below, so the semicircular canals and the vestibule will lie above the level of the facial nerve, clear? And once you cross this section of the facial nerve, you will be able to visualize the cochlea. This is one thing which is very important to recognize when you see the axial scans. One more thing is, if you are cutting a semicircular canal here, what you will get on the plate is something like this. You will see a black line in the midst of the white of the otic capsule. But if you cut it lower down, you are going to see 2 little dots. So that is how you are going to follow your semicircular canals, right? So let's see from above. This is the arcuate, just below the arcuate eminence. This is the superior semicircular canal. Next we go a bit down, and this white line starts going into 2 dots because we are cutting it just a little below. Okay, we go further below and this is 2 distinct dots with a channel in between, which is the arcuate tract, subarcuate tract, right? Next, you can see the beginning of the posterior semicircular canal. Clear? We go 1 cut below and we start seeing the shadow of the internal acoustic meatus. Clear? 2 things to remember here. You know this person? William House or Bill House, right? And the Bill's bar, isn't it? So the Bill's bar is something which is dividing the superior portion of the, the falciform crest is dividing it into superior and inferior. We are talking about the internal acoustic meatus. And the Bill's bar is And the Bill's bar is dividing the superior part into anterior and posterior, right? The anterosuperior part is having the key, facial nerve, and the anteroinferior part is having the cochlear nerve, and the vestibular nerve, superior and inferior, lie in the posterior part. So what we have to remember is when we are cutting axially, on the same cut, we are going to see the facial nerve and the superior vestibular nerve, right? And when we are going to cut it below, we are going to see the cochlear with the inferior vestibular nerve and the singular nerve if it is present, if you can see. So here we see the internal acoustic meatus. This is the anterior and the posterior lip. You have to remember, when there were no MRIs, this is used for diagnosing vestibular schwannomas as well, because the anterior lip is obtuse and the posterior lip, which is in relation to the vestibular nerve, that is acute. So the first sign on CT scan used to be erosion of the blunting of the acuteness of the posterior lip of the internal acoustic meatus, right? Sorry. So here we see this is the Bill's bar, which is dividing it into anterior and posterior. Anteriorly, this is the vestibular labyrinthine segment going anteriorly. This is the area of the geniculate ganglion. This is the greater superficial petrosal nerve, and this is the beginning of the tympanic segment, right? So as I said, the semicircular canals and the vestibule is going to be up to the level of the tympanic segment or the horizontal part. So here you can see the entire vestibule, the ampullated end of the lateral canal, and here you see the superior vestibular nerve. Okay? So is it clear? We'll go to the next slide. Before that, again I want to reiterate that the facial nerve will go anteriorly, give a branch here, again go posteriorly, and this is what has to be seen. The lateral semicircular canal, it is lying at 30 degree, isn't it? So it is lying at 30 degree to the axial plane. So the facial nerve will come like this and then it will go down at the second genu. So in the upper cut, you are going to see the anterior portion of the lateral canal and the tympanic segment of the facial nerve. As you go down below, you will see the posterior part and the turn of the facial nerve, right? So in the same thing, we won't be able to see it. Let's see. So here we see almost the entire lateral canal, but we see the anterior part of the tympanic segment, and we begin to see the head of the malleus and the body and short process of the incus. You can correlate this with anatomy. This is the body and the short process, and here you see this is the aditus, isn't it? And this is the antrum, this is the middle ear. Here you see the typical ice cream cone appearance of the head of the malleus and the body and short process of the incus. And what you also see is that when we see the entire tympanic segment of the facial nerve, we can see only the posterior part of the lateral semicircular canal, which I was emphasizing earlier, right? And you just, as you have traversed the horizontal facial nerve, you begin to see the cochlea, the uppermost part of the basal turn of the cochlea. Cochlea has 2.5 or 2 3/4 turn, and the basal turn has a superior basal turn, the middle basal turn, the lower basal turn, and then it goes on and becomes the middle turn, right? So this is the superior most part. Point to emphasize is vestibule and superior canal and the canals are above the tympanic segment, and as we traverse the tympanic segment, we will be going into the cochlea, right? You can see it here on anatomy. The entire vestibule is like this. These are whole bone sections, okay, so that you can correlate the anatomy and the radiology. I have this cut along this is the 30-degree cut along this is the ampulated end and this is the non-ampulated end of the lateral canal. So you can see if we take a cut above this, it is going to show the entire lateral canal with the vestibule, and a cut below this will show the entire tympanic segment. But we could not see it on our regular axial cut because of the 30-degree tilt of the lateral canal. Clear? So one cut below, we will see this one in greater detail. What can you see? You can see something fuzzy here. This is the cancellous bone, isn't it? Of which part of the modulus, right? So this is the cancellous bone of the modulus. You can see the basal turn and the middle turn of the cochlea. You can see here that this is you can see one line here. Can you see it? So this is the inferior vestibular nerve, and one line is going further posteriorly. As I said, when you start seeing the cochlear nerve, you are going to see the inferior vestibular nerve. When you are seeing the facial nerve, you are seeing the superior vestibular nerve. So this is the inferior vestibular nerve, and this line here is the cingular nerve going to where? You can clearly see that it is entering the ampulated end of the posterior semicircular canal. Cingular nerve supplies and part of the saccule. So you can see it here. How can you confirm this is the saccule? Because this is the foot plate. Okay, we have just seen the foot plate, and out here we are seeing the muscle of which muscle is this? The tensor tympani muscle, right? And the beginning of the processus cochleiform is the sharp projection is starting, which will become hook-like, and this is obviously the manubrium of the malleus and the long process of the incus. Clear? And we can see here that that horizontal facial nerve has now become vertical. This is the mastoid segment of the vertical part of the facial nerve, and just medial to it is the beginning of the pyramid. We will see it in a next cut. You compare it with the anatomy. So here you can see this is the modulus exactly as it was, the vestibule, and this is the foot plate, and here you see the long process of the incus and the manubrium of the malleus. One cut below, we will just magnify it. So this white line, this is known as the interscalar septum, isn't it, which divides the three turns of the cochlea, right? As you see the interscalar septum, you can very well see this is the facial nerve, this is the pyramid, this is the stapedius muscle with its tendon coming from the canal. So medial to this is the key sinus tympani, and this is the facial recess. So you can see the entire W of the sinus tympani, the pyramid, the facial recess. Okay, and here you can see this is the foot plate, this is the anterior crust, this is the posterior crust, the head, the IS joint, and the tendon of the tensor tympani going to meet the malleus. Okay, this is the entire posterior canal. Correlate with the anatomy here. You can see this is the interscalar septum, as we can see it here. This is the basal turn, this is the crura of the foot plate, the crura of the stapes, the foot plate, and the IS joint, and the posterior canal. So exactly like it is in the anatomy, you can see it on radiology. You just need to correlate it. Okay. We go one cut below, and you can correlate the entire interscalar septum seen here. The septum between the middle and the apical turn, you can also see that here, and this is the beginning of the lower part of the vestibule. This is the posterior canal. You can still see the pyramidal, the stapedius muscle and the facial nerve here. You go one cut below, and what we can see it, we will magnify this here. So this is the interscalar septa. This is the between basal and the middle turn, and this one is between the middle and the apical turn, and you can see one projection, faint white line. So what is that? Spiraling around the modulus, osseous spiral lamina. Okay, so you can even see that on the CT scan. Now point to emphasize is this is the round window membrane opening into the, as you can see, this is the osseous spiral lamina. So basal, will be the region of the basilar membrane. It is opening below it. So we know the round window opens into the scala tympani, right? So it is lying below that level. This is a mucosal fold, so this area is the round window niche, right? From the round window niche you can see a tract going towards the posterior cranial fossa. So it is key. মারবো ঘুষি cochlear aqueduct, vestibular aqueduct তো অন্য দিক দিয়ে যাচ্ছে, it is the cochlear aqueduct, তাই তো? So you can see it here, this is the round window membrane, round window mucosal covering and the round window niche here. I will not dwell on this. So you can very well see the cochlear aqueduct going from the round window region to the posterior cranial fossa. And here you start to see the horizontal carotid artery, right? So we have, this is, if we start from the neck, where is the carotid artery dividing? At the level of the hyoid bone, right? So external marking is at the hyoid bone. So you have the parapharyngeal carotid. So it will enter through the, as sir showed, in the opening on the undersurface of the petrous temporal, and it will become, go forward as the key petrous carotid. Then it will go up, right? So foramen lacerum theke it will again go up and it will become the paraclival carotid. Then it will go forward and it will become the cavernous carotid. Then it will go back like this. It will become, first is paraclinoidal process. So you have the paraclinoidal carotid and then it will go and divide. Okay, intracerebral way it will divide. So you have the two siphons of the carotid. Okay. So if we follow the carotid inferiorly, we are going to see that it is gradually going to become, you can see here the vertical part is becoming, horizontal part is becoming the vertical part, and you see the beginning of the key jugular foramen. We will see it on this one. This is known as the duct of the jugular foramen. This sharp spicule of bone is the jugular spine, okay, and the bone between the vertical carotid and the jugular foramen is known as the crotch, okay. So in jugular paraganglioma, the first bone to go is the spine, and then we see erosion of the crotch on the CT scan. That is diagnostic of jugular paraganglioma, okay, or glomus jugular. And you see this is known as the duct. This is the head of the duct, this is the beak of the duct, and this is the body of the duct. So body of the duct is making up most of the jugular fossa, and it is known as the pars venosa of the jugular foramen. And the anterior portion, this is the, which is the head of the duct, head and neck of the duct, that is the pars nervosa, which contains the key 9, 10, 11 cranial nerves, okay. And anterior to this, this is the region for the inferior petrosal sinus. Once the inferior petrosal sinus joins, it becomes the internal jugular vein, right? So here we can see two openings. This is the, as sir showed, this is the foramen ovale, okay, foramen ovale, and this is incomplete in this patient. This is the, because it is a very young boy, this is the foramen spinosum. And this is the region of the this is the anterior part of the petrous apex. So this is the region of the foramen lacerum, which is closed by osteocartilaginous, fibrocartilaginous tissue, right? So I will not dwell more on this because then we can cover a few pathologies. One very interesting slide I wanted to show you. Can you say what is this? This is the mastoid emissary vein, okay. So thrombophlebitis of the mastoid emissary vein gives rise to Grisinger's sign, which is edema over the occipital region. Undergraduate ra ei bhulta kore je it is edema over the mastoid. Grisinger's sign is edema over the occipital region more than the mastoid region, and it is diagnostic of thrombosis of the mastoid emissary vein. Because you can you can see that it is opening, this is the end of the temporal bone and it is opening in the region of the occipital bone, okay. So that is why I put this slide here. Now we will just run through coronal images. Here we see from anterior to posterior. So just like we cut the bone slice by slice from above below, we are going to cut it from forwards to backwards. Here again you have to remember that we will start with the facial nerve and the carotid artery again. So first we are going to cut here, then we are going to cut here, like this we are going to proceed. So if we cut the facial nerve far anteriorly, we are going to get the greater superficial petrosal nerve as a single dot. We cut it more posteriorly, we are going to get a wider dot which is going to be the geniculate ganglion. We cut it further posteriorly, we are going to get two dots side by side. So one will be the labyrinthine segment and the other will be the tympanic segment. So let's see. So we are starting here. So this is the horizontal carotid and this is the tensor tympani muscle, right? We go back, we see the tensor tympani muscle here and we just see a small white grey dot within the white bone. So that is the GSPN coming forward. Okay. We go further back and become a bit white. So it is the geniculate ganglion region. This is the thing and it has moved up as well. This is the beginning of the cochlea and here you can see the muscle. We see the head of the malleus, we can see the entire tendon. And if I don't know if you can appreciate it, there is one dot here and there is one dot here. So this is the tympanic segment, this is the key segment, labyrinthine segment. And you can see the cochlea has pushed the carotid downwards. So carotid has begun its downward journey to become vertical. You go further back and you see the opening of the carotid into the vertical segment and here you, sorry, oh. So you see the entire malleus, head, neck, and this is the manubrium and you see the tendon attaching here. You see the tympanic segment, the labyrinthine segment and the cochlea. Together this is known as the cobra head or the adder head appearance of the facial nerve. We can just appreciate the beginning of the internal auditory canal here. So if you correlate, you can see the cochlea. This is the internal auditory canal region. Obviously, this is from this side, this is the external auditory canal region and you can see the malleus from here. So once again we come to the same internal auditory canal. Here if we cut it vertically, what happened then? The superior vestibular nerve and facial nerve were together. Here the facial nerve and the cochlear nerve will be together. And if you cut it further behind, the vestibular nerves will be together. So this is it. We see this is the beginning of the facial nerve. Here we go a bit posteriorly and then we can see this is the superior vestibular nerve, this is the inferior vestibular nerve and this is superior semicircular canal, lateral semicircular canal and hanging like a grape we see the tympanic segment going to become the mastoid segment of the facial nerve, right? Because it is at this within the dome of the canal that this is going to happen. So you see it more distinctly here as the lateral canal becomes very prominent. You can see the facial nerve just hanging below it. Okay, and this is the superior canal. This is the region of the oval window. This is the region of the round window. We will see it more prominently here, where you can see the round window membrane, and this is the round window niche. Clear? Seen very well here on the section. Here we can see this is the vestibule, this is the round window region, this is the round window niche, and this bone has a particular thing. This is the region of the facial nerve and this is the sinus tympani, which can be seen even on the coronal section as well. It's not so well reproduced on the CT scan. Now I will show you the last cut to emphasize one thing. Whenever we say that during parotid surgery, that if we have reached the styloid process, we have gone through the facial nerve. So you can see this is the tympanic ring of bone, this is the styloid process, and this is the vertical part of the facial nerve. So you can well appreciate that this is lying medially, this is lateral. Let's go a few cuts and you can see here that the vertical segment has started to come down and this is the styloid. So the vertical segment is lying lateral to the styloid process. Okay. So if you have gone through to the styloid process, it means you have gone through the facial nerve. during parotid surgery. We'll go a bit down here, sorry. Here you can see two vertical lines. This is the facial nerve beginning its downward journey, and this is the stapedius muscle going upwards, and you can see this is the chorda tympani. So you have three vertical lines side by side. From lateral to medial, lateral most is chorda, second is the pyramid with the stapedius muscle, and the third is the facial nerve, which is most medially. We can see that the chorda tympani has branched off very low down. We know it has a variable branching. So from the bony canal of the facial nerve, it has almost at the stylomastoid foramen, it has branched out. So you have to be wary of that thing. Okay. So we come to the end. I'll not bore you with the Stenvers and Poschels. Just one slide I wanted to show you. These are the Poschels plane, which is the sagittal reformatting. You can see the facial nerve very well here. One slide, just bear with me here. This is the internal auditory canal. Okay, so you can see this is the falciform crest, which is dividing it into superior and inferior, and you can wonderfully see the Bill's bar coming down, dividing into anterior and posterior, right? So we are done with this thing. I'll just show you a few pathologies here. কতক্ষণ আছে? 5 minutes? I just wanted to emphasize one thing. You are going to do a CT scan for even before removing a foreign body from the paranasal sinus, isn't it? But sometimes you feel that even with chronic otitis media, we do not need to do a CT scan. Why will you venture into an area which has so detailed, so delicate structures rather, without doing a CT scan? And it's up to you how you choose to drink the water, isn't it? And the Bard himself has said, for there is nothing either good or bad, but thinking makes it so. If you change your thought process, I think you are going to change the way you look at it, right? Thank you. Download this software, it is free. It is known as Radiant Dicom Viewer. Okay. This is written up here, Radiant Viewer. The only problem is trial license is for 30 days. So you can change it every 30 days, but it will give you a wonderful view. You can do anything with the CT scan. Okay. So if you look at the CT scan, this is the right side. And you can see on this side, this is the facial nerve, this is the tympanic segment. There is soft tissue opacity within the mastoid and the middle ear, isn't it? But what we have to see, whether there is any erosion of the bone, right? So we can widen it, magnify it a bit further, and we can see that the bone that we see here, which is covering the fallopian canal, it is very thinly, it might be present or it might not be present. So when you are operating, you have to be aware that the tympanic segment of the facial nerve might be exposed, right? So you will be much more careful. So CT scan is going to provide you with that information. Why am I not sure? Because we have something in 3 dimensions, which is the voxel. Just 1 second, listen to me, because otherwise you might say confuse it. That the CT scan is acquiring data in 3 dimensions, isn't it? It is taking it as a cube. So that is known as a volume element or a voxel. But when we are seeing it, it is in 2 dimensions. It is either as a CT plate or as a 2-dimensional image. So the computer compresses the voxel into a pixel. From 3D it goes to 2D. So as this data is being compressed, if there are several structures which are of different Hounsfield units which are very near each other. So here you have the soft tissue of the chronic otitis media, you have the soft tissue of the facial nerve, you have the bone of the fallopian canal, everything is coming together. So when that is compressed, the computer distorts the image. This is known as the volume averaging defect. And then we are not sure whether if it is very thin bone, we cannot be sure whether that bone is present or not, right? So you have to be aware and you have to be cautious while doing the surgery. This is what I wanted to emphasize. So as you go down, you see that there is no erosion of the bone, but just soft tissue is present. So this is a mucosal type of chronic otitis media. Okay. So you can see it here. What do we have to look for? We have to look for erosion of the fallopian canal. We have to look for erosion of the ossicles, especially the, here we can see the foot plate very clearly, okay, but we cannot see the superstructure, and this is the long process of the incus, right? So there is nothing between the long process and the foot plate. So for all practical purposes, we can say that the IS joint is eroded. Is it clear? So you have to look for bone erosion, and on the coronal section, we can reformat it from here itself. So even if you don't have coronal, this software will allow you to, sorry. Yeah, we have reformatted it ourselves. We don't need to depend on the see here, this one. This is the scutum. What is the scutum? Scutum is the, yeah, it is a triangular piece of bone which is forming the lateral wall of the attic. You see how well it is seen here that it is triangular, right? Okay, and it is guarding the head of the malleus and the body of the incus. So you have to see whether that soft tissue is causing erosion of the scutum as well. Here you can clearly see that there is blunting, okay, the sharpness is lost. So you have to be aware that there might be bone erosion here, and also you have to look at the, as I showed you there, this is the lateral canal, this is the facial nerve. We are not sure whether bone is still present over the fallopian canal or not. So when you are dealing with the ossicular chain, you have to be aware that the tympanic segment of the facial nerve might be exposed, right? Right. So here you can see, we'll start from above. This is the facial nerve, this is the cochlea, this is the beginning of the tympanic segment. There is bone over the tympanic segment of the nerve, you can see it here. In the entire course, bone can be clearly seen. But what cannot be seen? Ossicles. So there is erosion of the ossicles here. In place of the ossicles, there just might be the head of the malleus, but incus is completely eroded, right? We have to check whether there is any fistula of the lateral canal, right? There is no fistula here. So I have to close it. The foot plate is here, but there is no evidence of the superstructure of the stapes. We can't see the stapes superstructure. So it means there is complete erosion of the ossicles. There is also, what is here? The lateral cortex is eroded. Okay. This is intact here, but out here there is erosion. This is the external artery canal, and this is a fistula on the outer aspect. Okay. Clear? So look for bone erosion, see whether the normal structures are present, and you can come to a diagnosis on the CT scan. Thank you very much, and best of luck for your exams.
Thank you.